So tucking is about achieving a more feminine kind of aspect to your lower body. So that's pushing the testicles up inside and either wearing some tight underwear or a few layers of undies or taping. But of course that's no good if you're donating, if you're needing to produce a sperm sample for cryopreservation, because the heat in the body will affect the sperm. And then readiness for hormones, and it's really about having that series of conversations with people, particularly with the hormones, because the thing about the puberty blockers is they're completely reversible. You can have someone on puberty blockers for 3 years, and when they stop, puberty just kicks off again. Whereas obviously when you start to take hormones, there are going to be some changes that happen in your body which are irreversible. So need to be, people to be clear about the decisions they're making and discussing potential side effects and potential risks, and we always get written consent, and there are consent forms on the health pathways that you can access. So I thought of just having a couple of made up cases just to, thinking about how in general practice you might respond. So I'm thinking about a young person aged 25 who tells you her name is now Sarah, you know the family, you haven't seen this person for quite a few years, and it turns out that they have had some contact with the DHB service, but that wasn't the right time. They were struggling with mood and anxiety, but things are a lot better for them now, and they would really like your help in transitioning, and they don't want to go back to that DHB service. And, for some people in general practice, you might want support, but for other people, you might feel comfortable to, with knowledge to support people. So this is what the health pathways look like. And there's lots of information there. Talks about medical history, what information might be pertinent before starting somebody on hormones. It talks about baseline investigations that you might like to think about doing before you're starting somebody on feminising therapy. And then there's information about what estrogen does to your body. So being clear in your mind about, the fact that changes are really individual between people, so they're quite variable and it takes time, nothing happens fast. So having some knowledge about the timeframes involved. For example, for breast growth, it really takes 2 to 3 years on a gradually increasing levels of estrogen to get the breast size that you're probably going to have as an adult. And in terms of just change in body shape, in terms of decreased fertility, mood changes quite variable. Sometimes people feel better, sometimes people feel more anxious. It's a very individual thing. Certainly it decreases erections and changes your interest in sex. Quite often the first thing that people notice is the softer skin actually, and decreased body and facial hair. So your facial hair slows down, but it doesn't stop altogether. And so a lot of people then need support around laser treatment. And then there's some information about prescribing the hormones there. So that's all on the pathways, thinking about whether or not puberty blockers are indicated or whether or not you're prescribing estrogen plus an anti-androgen. And so there's a bit more information here. So for the feminising treatment, you always need to have an anti-androgen in addition to your estrogen because you need something to block the testosterone. So puberty blockers will do that, and so we're often starting people on puberty blockers and then adding in the estrogen. But if somebody's older or they're not really wanting the injections or they're not going to have access to the subsidised Leukerin, then we often use the oral anti-androgen agents. So you can use things like cyproterone or spironolactone, but we use a lot of cyproterone in New Zealand. It's a really effective anti-androgen agent. and you only need a really tiny dose. The smallest tablet is 50, but you only need 25 milligrams for most people to really effectively block testosterone, to get the levels down below 2 and an LH less than 2. You do have to warn people about side effects, particularly mood changes, depression, so that might not be suitable for everybody. And in higher doses it can cause abnormal liver function tests. And so sapropterone's not FDA approved in the States because of the concerns about liver hepatotoxicity. And of course the anti-androgens are only really required up to the point if somebody decides to have surgery and remove testes, then it's no longer required. And estrogen, we're using estradiol valerate as the safest estrogen to use, and we usually start on a dose of 1 milligram and then just very gradually increase because that's considered to be best for best breast development. So really 1 milligram dose increases over a 6-month period, every 6 months. And usually people end up somewhere about 2 to 4 milligrams. You don't usually need higher doses than that. Some people may be up to 6 milligrams, but that when you look at different guidelines, they mention sort of 1 to 8 milligrams often, but that would be really the high end. Usually we find 4 milligrams is fine, maybe 6. And of course the estradiol patches are now fully subsidised, so for people that you feel have got risks in terms of thromboembolic risks, then prescribing the patches is the safest option. And in terms of risk, it's quite hard having conversations about risk. I mean, it's hard anyway, but also we don't have the data. I mean, we don't have the big prospective studies that we had, for the millions of women on the contraceptive pill in terms of risks for estrogen. But we do think that there's likely to be an increased risk in thromboembolic disease, cholesterol changes, increase in your triglycerides, and slightly increased risk of gallstones. And then possibly increased risks in blood pressure and liver abnormalities and increased levels of prolactin as well. So we don't have prospective trials for transgender women who are taking estrogen. What we do have is small retrospective studies that they've combined together and looked at the risk overall. And all you can really say is that the risks are lower with estradiol valerate, because people used to prescribe the ethinyl estradiol, but we certainly don't do that now, because estradiol valerate has been shown to be a lot safer in terms of reduced risks, and lowest again with transdermal estrogen. Thrombotic risk is highest in the first year of starting treatment, so you do have to do some kind of baseline risk assessment to think about, if the person's got a high BMI or a smoker or a family history or that kind of thing to make that decision. And again, as you get older, your risks increase. So usually we're thinking about transdermal estrogen if somebody's over 40 years of age. And then monitoring maintenance therapy. So certainly maintenance hormonal therapy is definitely best done in primary care, because there's just no way that DHB services can continue to prescribe maintenance treatment for everybody. That would just be crazy. I mean, I think secondary services definitely have a role in helping people through transition, but then primary care is the best place to be looking after general medical care. And so there's lots of information in the pathways about how to support someone who's on maintenance feminizing therapy, in terms of checking in about mental health issues, checking blood pressure and BMI, risks like smoking, and what kind of investigations you might want to be doing routinely for people. And then what about another scenario where you've got a new patient who's registered with your practice?
So can I just ask about that last one? Mammograms?
Yes, yeah, just as per national health screening guidelines, yeah. So there's no evidence that there's increased risk for trans women on estrogen, and they should just take part in the normal, national mammogram kind of guidelines. Yeah. There certainly have been case reports too for trans men, even after chest reconstructive surgery of having breast cancer. So I guess it's just being aware of that. Yeah. So if we think about another imagined scenario, a 22 transgender male who's just moved to Auckland, family supportive, works at St John's Ambulance, stealth at work, so nobody at work is aware that he's a trans guy, has been under the care of the DHB service and is now being discharged to primary care, and he's now stable on maintenance Reandron, testosterone injections, and he's had chest reconstructive surgery last year and is very pleased with the outcome. And you've got a discharge letter from the DHB service, but there's not really much information in the letter about ongoing care. So again, being a little bit aware about testosterone and the time frames of change in your body if you're taking testosterone. And again, it's quite variable and everything takes time. Often the quickest thing to change is your voice, and once your voice is dropped, of course it's dropped. And some people are quicker than others, some people it takes a few months, but it's really not till a full year that you've bedded in with your new adult male voice. Facial hair is very variable, as it is with all, men going through puberty really. Some people are very hairy and some people take ages to get a little bit of hair. You do get a change in your external genitals. The clitoris usually typically enlarges by about 1 to 2 centimetres. And you tend to get more interest in sex, your skin changes, you get more oily, a lot of people get acne starting on testosterone, and eventually, usually after sort of 3 to 6 months, your periods will stop, and with time you tend to develop a vaginal atrophy, so the vagina gets quite dry. So those are all the changes, and there's actually some nice research done, I think maybe in Dunedin, or who was New Christchurch, where they interviewed some partners of people that were going through transition, and one they were talking about a couple, and there was somebody who was taking masculinizing hormones, and the person who was in the relationship with that person, even the smell of that person changed going through hormonal transition. So it really has quite big changes in your body.
Vaginal dryness and bleeding as a result of that.
Yeah.
Someone who's been on testosterone for a while, how do you manage that?
Yeah. I guess.
Not with overstuff.
Well, that would be an option.
Would it?
Yeah. Because it's not hugely systemically absorbed, but it's going to make a difference locally.
Right.
Yeah. But they're tricky conversations with people because clearly it's a female hormone.
Yes.
Yeah. But it's going to be the most effective.
And it shouldn't have too much, the dose of the testosterone, would that need to be changed?
No. Because the Ovastin should be just locally absorbed. It shouldn't be a lot of systemic absorption. Yeah. So testosterone, it's a little bit trickier because it's specialist only medication, and it comes in various forms, but once somebody's started prescribing it, you can continue to prescribe it. So often we start people off on the short acting testosterone like the Depot-T or Sustanon, which are 3 weekly injections, 2 to 3 weekly. And often people can learn how to self-inject. So we get people up and running and they learn how to self-inject and off they go. After time, some people prefer, once we've built up the doses, some people prefer to switch over to the longer acting testosterone, which is Reandron. And that's a 12-week injection, or 10 to 14, but usually about 12 weeks. You can't self-inject the Reandron because it's 4 mils of quite a viscous solution that's got to be given, like a deep IM injection. So that needs to be given by a nurse. And some people prefer being on the Reandron because it's got a more sort of steady state level, so a lot of people feel better on the Reandron, whereas the Sustanon, you get a more kind of sawtooth drug delivery into your system, so you get people feeling good, and then a couple of days before their next injection they're feeling a bit flat and low, so it tends to be a bit cyclical in that way. But obviously if you're self-administering your testosterone, then you've got more freedom. So I've also had people say, I prefer to stay on the Testosterone because that gives me more independence. So it's just decisions that people make, really. And being mindful again that testosterone is contraindicated in pregnancy. Risks for testosterone, again, we always say, well, the full risks are not really known. We don't really have good, really long-term information, but certainly there's likely to be an increased risk of polycythemia, and so we do monitor hematocrits. Likely to be changes in your cholesterol, so you get an increase in the LDL and a decrease in the HDL. And there's certainly no information about there being increased risk for breast cancer or, importantly, cervical, ovarian or uterine cancer, because there was some concern initially that if you're giving someone testosterone, it will get aromatized into estrogen and then you might be putting people at risk. But as time's gone on, I think we're all more comfortable with the fact that long-term testosterone doesn't appear to have any increased risk of endometrial cancer or ovarian cancer. And in fact, if you do pelvic ultrasound scans on people who've been on testosterone for a while, you tend to find very thin endometriums and atrophied ovaries, is what you see. And lots of information on the pathways about maintenance, treatment, prescribing, and what blood tests you might like to think about doing in terms of monitoring hormone levels, and really aiming for normal male hormone levels, so testosterone levels within the normal male range, and estrogen levels tend to be, the estradiol levels do tend to be quite variable, but tend to be lower down towards the female range.
So do they also need the anti-estrogen therapy or a puberty blocker when starting testosterone? You emphasise that for the opposite situation?
No. I mean, if I'm seeing a young person who's 15 or 16 and wanting to start masculising therapy, sometimes usually we start the testosterone or the cross-sex hormones at 16, tends to be the age at which we start, because it's the age of consent. So if someone was 16 or 17, they might just want to start straight on testosterone. It might take a bit longer to get bleeding cessation, so that if they were particularly distressed about bleeding cessation, then I might start on a puberty blocker as well, because that will achieve it more quickly. Or if somebody just needed a bit more time to think about starting testosterone, then I would use a blocker. But then also I've worked with young people who have said, no, I don't want the blocker, I just want to start the testosterone, and that's absolutely fine.
Because I have a patient and she's been given Depo-Provera to stop her periods, and he's on testosterone now. But really distressed a couple of months ago with a period. So we were advised to give a Depo-Provera.
Yeah, I mean that would be another option. Yep. As well as a Leukerin, and instead of a Leukerin injection, instead of a GnRH blocker, you could use Depo. Yep.
Absolutely, because that's one of the first things you could do for distress for somebody coming, identifying as male, put a Depo right there, to at least try to alleviate that distress.
Yes, absolutely. Yep. Yeah. And also, sometimes we have people on Depo and testosterone if we're concerned about contraception risk too. So we certainly do that. Yeah. So they're all just really different options, and it depends on the person who's sitting in front of you, what their primary stress or anxiety is and how best. So I usually just talk through the options with people, and people will get a feel for what actually is going to best suit them. Yeah.
Because this person's not been offered a puberty blocker, this patient but is just on testosterone and Depo-Provera to suppress periods. So he should really be on a puberty blocker at 19 then. Well,
at 19 you're getting a little bit older, because don't forget the Leukeron's only subsidised for adolescents. So, I don't think it's wrong to be on Depo. Yeah. Some people are fine with that. Some people just don't want anything to do with any kind of female hormone and would find that being on a GnRH blocker would better suit them. Yeah.
And if someone's gone on the testosterone, then they don't really need to keep doing blockers because it's
eventually,
it smashes all the other everything else.
Yeah, that's right. So there's a bit of an overlap. You don't continue the blockers indefinitely. Yeah. But once you're sure or feel confident that somebody's probably achieved bleeding cessation, then you stop the blocker and they just carry on their testosterone. Yeah.
Can I ask, so use of Mirena for trans?
Yeah, or even the copper IUD. Because once you've achieved bleeding cessation on, if you're thinking about contraception, if you achieve bleeding cessation on the testosterone, then a copper IUD would be fine. Yep. Or if you're trying to achieve bleeding cessation, then a Mirena. Yep. Yeah. A few other things to think about when you're working with people who are gender diverse. Binding. So that's the process of wearing a very tight-fitting upper body garment that gives your chest a more masculine form. So a lot of our trans guys will bind, and that can cause health problems. Certainly it causes rib pain, back pain, discomfort, difficulty breathing when you're trying to exercise. So it's worth thinking about that. And surgery. So in Auckland we're relatively lucky in that we are getting access to some surgery, and I'm aware that DHB by DHB the circumstances will be very different. But in Auckland we do in theory get access to breast augmentation under the regional plastic surgical team for transgender women who have had zero response to estrogen. And we do get access to orchidectomies, but not really the other surgeries. Now, in terms of genital gender affirming surgery, you might be aware that in New Zealand we haven't had anyone who's been trained since Peter Walker retired in Christchurch, which was a few years ago now. But that situation is about to change because the Auckland Regional Plastic Surgical Team have had a fellow who's training overseas, and she's about to return to New Zealand at the end of this year. So we will, next year in New Zealand, if it all goes to plan, have somebody in New Zealand who is trained to do genital gender affirming surgery, both for trans women and for trans men. How that will change things I don't know, because it depends what kind of funding package they put around that. So that all remains to be seen. And I notice there's been no announcement, so I'm picking that everyone's just waiting for the election and wait till afterwards. What we do have access to Auckland though is chest reconstruction surgery for trans men, and again that's under the Regional Plastic Surgical Services. And we've got some access to hysterectomies too. And we've been working with the plastic surgical team because while they're very supportive, there are issues of capacity, and then so it's all a little bit tricky, but we are getting surgery.
What's a metoidoplasty?
Yeah, so that's, I knew someone was going to ask me that. Basically it enables you to pee standing up, but it's the clitoris is brought forward and something else happens to the labia.
Okay.
I'm no surgeon. And you might be aware at the moment, we've got this arrangement that the Ministry of Health hold this high cost treatment pool of money, which is designed to fund very rare events, like if somebody's got a rare cancer and needs some special oncology drug. But in fact what they're using it to do is to fund genital gender reassignment surgery at the rate of 3 feminising surgeries and 1 masculising surgery every 2 years. But in fact the system's not really working because the waiting list is literally 50 to 60 years old. It's just, it's clearly it's not working. And there's been submissions to the Ministry of Health, and they're aware it's not working that well, but what's going to happen next is, I guess, unclear.
So excuse me, does there get private insurance? Would that be covered in insurance for that for you overseas if they?
Yeah. Well, I don't know about your private insurance.
Like if you ever had like something cost insurance, if you had that. No.
Oh, yeah. I mean that would be up to your insurer, but
where they normally are or not.
Yeah. People usually pay privately to go overseas.
And what sort of?
Yeah, about 20,000, I think they said.
Thailand,
For Thailand. Yeah.
Phuket the big place at the moment, wasn't it?
Yeah.
For trans.
Yeah. In Auckland, I think it's about 10 for chest reconstruction for private, so we do have people that would prefer to pay privately, or families that will pay for their child to go privately. And of course then there's other things. We do have access to voice therapy in Auckland, and again that's DHB funded. That's just working with the speech language therapy teams who provide voice therapy to achieve more gender neutral pitch, so that's often really important for a transgender woman. And we don't have any funded access to laser treatment, but that's obviously something that is quite important for people. And then just recognising really that patients who are gender diverse experience the same health problems as everyone else, and there's really very few differing needs, and primary care is the place to support that. And certainly in terms of cancer screening guidelines, just thinking about what the normal national guidelines are for people who still have breasts or a cervix or a prostate gland. But being aware that lots of gender diverse people find cancer screening can be physically and emotionally challenging, and to be sensitive around that. So just a couple of quick slides on cervical smear tests for trans men. Acknowledging it's a different experience. As Ahi said, thinking about language, what people prefer to call organs. And I work with some trans men that say that just call it what it is. I'm quite happy to be, to talk about a vagina, and other people find that more uncomfortable. And just being aware that testosterone can cause vaginal dryness, so thinking about lube or even estrogen for 2 weeks prior to your smear test as an Overston cream. Being aware that testosterone makes genitals look different, so the cervix might look different, the clitoris enlarges a bit, but that's clearly not the time to have a discussion about that. You're doing the smear test. Not making transgender people feel like they need to provide an education session, and I heard several people talk about going on the journey with patients. Which is, it's absolutely what it is, but it's also often exhausting for gender diverse people to feel that they have to educate their health providers. And also just making sure that you write clear information on the smear test form so that you're not confusing the path lab about the sample that you're receiving when the NHI says male. So that brings us on to NHIs. So Ministry of Health are very clear that you can choose what name and gender you want against your NHI, and there's a process for changing people's genders against the NHIs, so that's easy to do. And then we also support around other legal kind of aspects, and certainly Passport Office have done a really nice job of making it very easy to change your gender on your passport. Much more difficult still to change your gender on your birth certificate. That involves a family court, and I've got one family that's going through that process at the moment, but it seems to be a very slow process. We haven't got there yet.
One thing that you can't do is change your NHI, which...
No, you get the NHI at birth.
So you get your NHI.
I know the Ministry of Health do have a working group around this, and we're hoping for some guidance from them.
Great to have a place to silo some information so that it's only available if the patient allows it.
Yes, yeah. And I think the other thing to be aware of too is in terms of gender health services around New Zealand, I think the Ministry of Health has been quite clear in that they feel that it is their view that regional services will be developed by DHBs in that region. And just some great resources there. This is the resource that Ahi has been involved in producing, which is a fantastic website, the Gender Minorities. Great resources on Rainbow Youth too. And we've got the Asia Pacific Transgender Network, which has got lots of information sheets, and some great booklets by Elizabeth Kerekere, which are really beautiful, the Takatapui booklets, and from Human Rights Commission. To Be Who I Am is a great document that's, I think, 2012, and they've got other information too, and just have fun too. That's some of the Centre for Youth Health team on where gender health varies on the Pride Parade. So thank you.